before I start, I just want to mention some of the housekeeping rules. Please, if you're not, actually, let me do this. If you're not speaking, please mute your phone. You're welcome to be on camera if you want. So I just want to let everybody know that today's topic is regarding risk of type 2 diabetes, post-gestational diabetes. The special guest here today is Dr. and the only Teirra. She's expert on this particular topic, and she has done a lot of work in diabetes, and I'm very pleased to have her join us in this podcast to be able to describe the work she's done, in Indiana regarding this work. Also, I think I always do a quote, and this time around, I selected another Igbo quote from Igbo tribe. It means another Ekuchiafi Maka. The English version of this quote is that you cannot cover pregnancy. Again, it's a lot of cultural meaning to this. It doesn't literally mean pregnancy. It means pregnancy in this case means truth, honesty, a lot of integrity. You can't, no matter how you try, it will always show up somehow. So we will see that come true in this particular study on what Dr. Teirra has done. So before I go into introducing Dr. Riggs in this podcast, I had to actually talk a little bit about diabetes, so our audience will have an understanding about diabetes. So the risk of type 2 diabetes specifically include gestational diabetes, or giving birth to baby who weighed over 9 pounds. Another risk of type 2 diabetes is prediabetes, overweight and abnormal BMI, both men, women, children, is a risk factor for type 2 diabetes. Age, usually people 45 and older have higher risk, but anybody can have a type 2 diabetes at any age. Familiar history is a big risk factor for type 2 diabetes. Physical inactivity is also a risk factor. In fact, CDC indicated that physical activity less than 3 times per week, is considered, a risk factor. Race and ethnicity: African Americans, Hispanic, Latino, American Indians, Alaska Native, Pacific Islander, and Asian Americans have higher risk of type 2 diabetes. Why are we doing this today? If you look in the United States, the prevalence of type 2 diabetes is about 9%. This is about 2021 data. Now, if you look at it over more than 37 million people in the US have diabetes. The medical cost and lost work wages for people with diabetes is over 327 billion yearly. And I say billion with a B. So 327 billion yearly. Diabetes is 8th leading cause of death in the US, number 1 cause of kidney failure, lower limb amputation, adult onset blindness, and a leading cause of heart disease and stroke. Now I live in California. California prevalence of type 2 diabetes is 11%. That's above federal level, which I just mentioned, 9%. And it's also in California a leading cause of death in California. Now, I say all this to say that type 2 diabetes can be prevented or delayed with lifestyle modification, including healthy nutrition, weight loss. For individuals who are overweight, there is no shame or guilt. This is pure science, and we can do this. We all can do this. So And that being said, I'm happy that Dr. Teirra did this study. And let me introduce Dr. Teirra so everybody understand this expert and the work she has done and she will continue to do. Dr. Riggs works at Indiana Department of Health as the Diabetes Prevention Coordinator in 2020, working with sites across the state to adopt the National Diabetes Prevention Program through the CDC 1815 grant. Dr. Ray has guest lectured at university in Indiana, including Indiana State University. So that's several universities in Indiana she has lectured. She covers several health topics, including, but not limited to, mental health and stress, substance abuse, and applied health and wellness. Dr. Ray has over 10 years of professional experience, including behavioral health care, diabetes education, mental health awareness, teaching, and care coordination. Dr. Riggs is passionate about informing the public of the impact of diabetes in the state and ways to increase awareness about prevention methods in diabetes. So without further ado, I will hand it over to Dr. Riggs to give a shout out to her colleagues and anyone that have helped us so far to get to where she is right now. Thank you so much, everyone.
Thank you so much, Dr. Omalu. Good afternoon, everyone. I am excited and delighted to be here today and to go over my story and my research. But before we get started, again, I want to give a couple of shout outs to my Super 7 participants who were so transparent, open, and trusting of me with their sensitive experiences during my research study. Come here. To my son, Willie Jr., who remains the best part of me and who truly put me back together again. I love you. Thank you. To my friend, Ndikaku, who continues to ignite my flame in serving, researching, and making a difference in my area of expertise. And finally, to my friends and family who show endless love and support now and forevermore. I thank you so very much.
Good stuff. So before we dive into this, I know there's a lot of stories about you personally, and also you have done a qualitative study looking into women, specifically African-American women who had gestational diabetes during pregnancy, to understand their risk, whether they even understand their risk to type 2 diabetes. But before I dive into this, I want you to tell your story. And in telling your story, I want you to incorporate the problem, the background, and the purpose and significance of your study.
Thank you so much. Again, I thank you for this opportunity and allowing me to share my story as well as my research. So I invite you to travel back with me to about a decade ago, where the year was 2013. I experienced my very first pregnancy that ultimately resulted in an unexplained stillbirth after 20 weeks gestation. Soon followed the postpartum depression, the post-traumatic stress, the anxiety, the suicidal ideation, not having an explanation of what happened, that soon created a container of fear, anger, and uncertainty that then fueled my doubts in wondering if I'd ever be a mother or a functioning student or person. With little follow-up care and no diabetes diagnosis documented, I continued my journey with life and as a doctoral student. The following year, I became with child again, and I was diagnosed immediately and treated as an insulin-dependent type 1 diabetic / gestational diabetic at 6 weeks gestation, with at that time, I had a fasting blood sugar of 450. At 9 months, 37 weeks, I delivered a small for gestational age, 4-pound, 10-ounce baby boy. Born under significant stress and to a mother with diabetes, he was hypoglycemic with a dangerously low blood sugar and intensive care for his first week of life. After 6 years of me experiencing medication mismanagement, hospitalizations, being misdiagnosed, and perfecting the art of self-advocacy, In December of 2020, I was finally diagnosed with type 2 diabetes. Still dissatisfied and challenged to change the trajectory of my life, in 2022, I moved across the country, stopped taking my medication, and created my own path to wellness. I am now diagnosed as a pre-diabetic with a standing A1C of 6.4. I now manage my life now with diet, exercise, and a lifestyle change. Through my story and research study, I vow to continue to elevate the voices of African American women who may have or will experience what I did. I am here for a cause, and I know this area of research because I have lived it. Marginalized women, particularly African American women's experiences, are valid and deserve to be treated with optimal respect and care. Believe Black women. Pregnancy in African American women has become a preventable public health crisis. So the problem I addressed in my research study relates to African American women, gestational diabetic pregnancies, and their perception of risk to type 2 diabetes within 7 years after pregnancy. I focused on the state of Indiana due to my personal experience, and that in Indiana, 1.4% of women were reported to have gestational diabetes during their pregnancy. But of that small percentage of women with gestational diabetes, 40 to 60% are at risk for developing type 2 diabetes within 5 to 10 years. And approximately 5 to 10% of those are at risk for developing type 2 diabetes after giving birth. So to give you some background of my study, mutually exclusive research report that African American women face high long-term type 2 diabetes risks after pregnancies at up to 60%. Research also shows that gestational diabetes does not always show a higher risk in African American women. However, they are at a disproportionately higher risk for developing type 2 diabetes later in life. African American women have a higher prevalence of type 2 diabetes conversion, yet they are understudied and underrepresented in data and have lower care during and after pregnancy. The gap of the prevalence of gestational diabetes in Indiana is widening as well. And with that, I addressed that in my research study. So to provide some purpose and significance of my study, the purpose of my purely qualitative study was to explore the lived experiences and perceptions of risk of developing type 2 diabetes as expressed by 7 African American women who reside in Indianapolis, Indiana, and who were diagnosed with gestational diabetes. The goal was to spark constructive and culturally tailored conversations to discover approaches to improve health status and conditions of African American women after experiencing gestational diabetes to reduce their risk of type 2 diabetes. This study is significant because it offers essential experience at both the personal and public health levels. The knowledge acquired from my study as of late is being disseminated to the stakeholders in Indianapolis, Indiana, including the Indiana Black Breastfeeding Coalition, African American communities across Indianapolis, healthcare professionals, advocate groups, and other vested groups or organizations. Sharing the findings of this study with vested stakeholders, African American women's quality of life can and will improve, and the prevalence and incidence of gestational diabetes and type 2 diabetes among African American women may be reduced. Most importantly, these understandings inform the individual level and provider-based understandings on how targeted interventions in African Americans living in Indianapolis, Indiana can be improved. The use of effective self-care among patients is fundamental to reducing the risk in gestational diabetes complications.
Thank you, Dr. Riggs. I know there's a lot we need to cover in this particular topic, but the most interesting part is yet to come, and the test of the pudding is in the eating, and that eating and the test is actually in your findings. But before we get to those, let's talk about the research questions that you addressed in this study. And also, while talking about that, let's also talk about a full summary or detailed description of the theoretical framework you use and the methodology you use in conducting the study.
Okay, thank you so much. So again, going over the research questions in my study, 2 research questions guided this investigation in gaining an in-depth understanding of African American women's lived experiences and their perceptions of risk in developing type 2 diabetes after gestational diabetes. And they are, number 1, what are the lived experiences of African American women after experiencing gestational diabetes within the last 7 years? And number 2, what are the perceptions of risk among African American women developing type 2 diabetes in the future after experiencing gestational diabetes? The theoretical framework and the model that I used for my study. Again, this was a purely qualitative research study, meaning all information gathered from this study was subjective. Hermeneutic phenomenology was the research design and the foundation for my study. So why hermeneutic phenomenology? Or rather, what is it? Hermeneutic phenomenology is also known as interpretive phenomenology, and it focuses on the subjective experiences of individuals and groups. It seeks to understand the deeper layers of human experiences that lie obscured beneath the surface awareness and understand how an individual's life world, or the world as they experience it, influences their worldviews. I used Max Van Manen's 6 research activities as the theoretical framework for my study. The methodology included a demographic survey, a focus group interview, and one-on-one interviews, all completed through the virtual platform Zoom. Keep in mind, this research study was completed during the active phase of COVID, which explains my virtual format for collecting my research. The methodology, again, I used a qualitative research method and a hermeneutic phenomenological research design to explore the lived experiences of African American women in Indianapolis, Indiana, who had gestational diabetes, to understand their perceptions of risk to type 2 diabetes in the future. Max Van Manen's hermeneutic phenomenology is a systemic process designed to discover and describe the internal meaning and structure of a real life situation in a natural setting as one's day-to-day life in the world. So I utilized this to unveil how African American women's lived experiences of gestational diabetes inform the risk of type 2 diabetes later in life.
Wow. Okay. I think we're getting there. So now that we know your story, and now we know your methodology you use, this is qualitative study, and also know what you went through, going through that experience with your first baby that you lost due to diabetes or misdiagnosis. Can you now go into detail in explaining the findings of your study?
Happy to do so. So now I present the meat and the bones for the study. So please bear with me. The findings of my qualitative study produced 9 essential themes in both research questions to inform gestational diabetes and type 2 diabetes prevention and optimal management at the individual, social, and community and institutional levels. And before I dive deeper into the findings, I want to go over why I collected a demographic survey. I collected this inclusive criteria to really highlight the standings in which the African American women were. That included their age, that included their educational level. Do they work currently? Do they have any other children? Do they have gestational diabetes in any of their past pregnancies? The number of times they had been diagnosed, and if they have a familial history of anyone in their family that has diabetes. This was important to really showcase that these women that I interviewed were college-educated women who were well aware and capable of some of the conditions that they had. So, to address research question 1, 4 of the themes, constituting 44.4%, include lack of social support, gestational diabetes, mental health, emotional distress, and depression, and finally, complications. These 4 themes emerged and were identified from lived experiences after experiencing gestational diabetes to, again, address research question number 1. These themes are presented in a frequency of descending order of priority to emphasize the ordering of importance of the themes. So in other words, lack of social support occurred most, followed by gestational diabetes, mental health, emotional distress, depression, and finally complications. So now to expound on each of these themes. The lack of social support was the most common theme from this entire study. To expound on that, all the women that I interviewed, 100% of these women indicated an absence of social support, and the sub-themes associated with this included fear and uncertainty, lack of communication, lack of resources, and information about their gestational diabetes. These themes were stated for a total of 212 times based on the thematic analysis frequency count. Specifically, all 7 women experienced a lack of communication with resources and information pre and post gestational diabetes, which verbalized their fears and doubts of outcomes regarding obesity, weight gain, and weight management. The second theme was gestational diabetes, which included a specific sub-theme of monitoring and tracking. This was mentioned for a total of 99 times based on the thematic analysis frequency count. Again, 100% of the women indicated that their gestational diabetes health condition and experience was a critical yet incessant process. What does that mean? These women expressed either having been made aware of gestational diabetes, yet being somewhat unprepared to manage, or they were initially shocked of their gestational diabetes diagnosis altogether. All of the women stated how their pregnancy outcomes could have been improved with increased opportunities for routine gestational diabetes screening before and after pregnancy. The women who participated in the study suggested the need to enhance gestational diabetes preventative measure approaches in medical care settings. 100% of these women further expressed their lack of preparation to deal with gestational diabetes and how their emotions changed during pregnancy and the lack of quality follow-up treatment. The third theme mentioned in my study included mental health, emotional distress, and depression, and included the following sub-themes: denial, despair, negligence, blame, child loss, and racism. All of these inform the connection between gestational diabetes and mental health outcomes. All of the women that I interviewed for my study described their poor mental health state, their emotional distrust and distress during and after being diagnosed with gestational diabetes. The women shared concerns about medical professionals' failure to employ tailored best practices and reasonable care during and after pregnancies to address their health needs. 3 of the 7 women, 43%, mentioned despair and denial, emphasizing the absence and loss of hope after their pregnancy, describing not being heard or understood while speaking to healthcare professionals. One participant even mentioned the loss of a child during her gestational diabetic pregnancy experience, which created a an understandable traumatic impact of gestational diabetes. The 4th theme to address my research question number 1 directed a focus on complications. Sub-themes for that included misconceptions, obesity and weight, and outcomes that occurred during and after their pregnancies. 100% of the women described 1 or more complications during and after their pregnancy, specifically on weight after gestational diabetes. All of the women spoke of their lived experiences about gestational diabetes misconceptions, specifically regarding weight gain. One participant stated, and I quote, I gained a lot of weight during and after my pregnancy. I don't know if it was a combination of stress, being pregnant, taking insulin, and being overwhelmed. The misconception of African American women's gestational diabetes experiences can be positively mitigated as it is attributed to persistent health disparities and negative health outcomes that persist as barriers to providing quality medical care. The 5 remaining themes addressed research question number 2, and they are reflection, health literacy knowledge, social determinants, social inclusiveness, and finally, acceptance. These themes are also presented in a frequency of descending order of priority to further emphasize the ordering of importance of the themes. The fifth most common theme mentioned in my study was reflection. And I want to add that self-motivation was the only sub-theme in this entire construct. So 100% of the women highlighted a sense of reflection with a total frequency of 86 times during the thematic analysis frequency count. All the women interpreted common perceptions of their beliefs of type 2 diabetes, and prevention was either antiquated, outdated, or that the chronic disease was difficult to prevent altogether. 100% of the women expressed self-reflection, illustrating their belief and or risk to type 2 diabetes, inclusive to either being a hereditary factor or their levels of control of type 2 diabetes risks, basically their lifestyle. The sixth theme that emerged from my study was health literacy and knowledge. The women referenced health literacy and knowledge 54 times in the narrative responses. All of the women interviewed expressed a lack of knowledge regarding their risk to type 2 diabetes, but were pretty well informed about gestational diabetes. In general, the women also expressed either a lack of health information knowledge, misunderstanding of type 2 diabetes diagnosis, or had a moderate level of comprehension. Most of the women were able to articulate gestational diabetes understanding, but lacked knowledge regarding type 2 diabetes, including misunderstandings. The lack of health literacy on the risk of type 2 diabetes affects lifestyle behavior and response to the chronic disease later in life. The seventh theme slightly shifted a focus on social determinants of health. The women who participated in this study conceptualized their perceived risk of type 2 diabetes as influenced by social determinants of health regarding their beliefs, health literacy, and socioeconomic factors, including education. Conversation regarding access to clinical preventative practices was discussed during the focus group and one-on-one interview sessions to understand the social environment knowledge that the women had about gestational diabetes and the risk to type 2 diabetes surfaced with all but 2 participants. In essence, 6 of the 7 women indicated that socioeconomic factors do influence type 2 diabetes education. Based on their accounts of knowledge of type 2 diabetes, most of their education about type 2 diabetes was acquired through an independent source with minimal assistance from healthcare professionals. The 8th theme that emerged was social inclusiveness, essentially reinforcing adverse impacts of the risk of type 2 diabetes among African American women. One of the women expressed their experiences on how they are perceived by medical professionals by stating this, and I quote, "What applies to one African American woman may not apply to another African American woman. One nurse kept saying to me, well, African Americans usually have big babies." The women also expressed common interests and experiences in improving their ability and opportunity to educate and be informed about type 2 diabetes. And finally, the 9th theme that emerged from this qualitative research study was acceptance. The women spoke extensively about circumstances that increase or decrease type 2 diabetes risk, while others perceive their type 2 diabetes risk as being inevitable since they are already at risk. One participant stated, well, the fact that I am prone to type 2 diabetes already from being pregnant, I believe it's in my system. Lifestyle changes may be such as exercising daily and eating healthier. One participant expressed her thoughts about type 2 diabetes risks acceptance as follows. I believe weight plays a huge factor and or genetics. Personally, these are things I've read and being in the healthcare field. So the findings of my study supported other studies that indicated that African American women are at a higher risk for type 2 diabetes because they have a high prevalence of obesity, being overweight, having high blood pressure, high cholesterol, and a low rate of physical activity.
Wow.
Social, do you want to go over the social
No.
implications?
I'm just so overwhelmed. Go ahead. Continue.
So just briefly to address the social implications of this study, African American women without diabetes, but with a history of gestational diabetes, are more likely to be diagnosed for type 2 diabetes, including higher blood pressure. The effectiveness of self-care for patients exhibits inherent gaps. So enhanced policies and best practices should be implemented in both medical systems and in public health.
Yeah, so, and I think we will dive into that because, like I mentioned earlier, $327 billion with a B. I mean, type 2 diabetes can be prevented. Type 2 diabetes can be delayed. There are so many things that people can do, the government, the policies in public health, the best practices in clinical services, individual level efforts can help reduce the prevalence and incidence of type 2 diabetes. These are preventable type of disease. So, but that being said, what are the overall lesson learned in your study? And also, actually, let's talk about the lesson learned, and then after that, we go into practical applications of all the findings.
Okay. Lessons learned in my study. This study provided foundational knowledge on how public health and medical experts can effectively address missed opportunities to lack of quality health care among the population of African American women and communities across the United States to enhance quality healthcare delivery. African American women require mental health assessments and management to improve their quality of life. In terms of public and medical care best practices, the lack of quality clinical linkages and resources created stressful emotions and mistrust towards the healthcare system. So basically, you want to saturate yourself in the applications of your research because that's how you meet people where they are. You want to develop a methodology that meets their psychology, which is why hermeneutic phenomenology was the best approach for me to gain the raw, deeper, and unfiltered responses from the target population in my study.
I will not let this fly. The methodology that meets their psychology. Can you expand on that?
Happy to. So when I'm very big on this concept of meeting people where they are. A lot of times there's a lot of intimidation when we step into, doctor's offices or medical care practices. There's this myth, we just take everything for face value if they have a white coat, are they wearing a white coat? And it's important to understand the art of advocating for yourself and asking these questions. And so when you want to develop something, you want to ask the questions of the participant to see where they are. Where's their psychology? Where's their head at? How's their thought process? What are they thinking? And then from there, you can create a methodology or a way to meet them, and so they can understand the language that's being said, where you can try and work on solutions and best practices. So that we can delay or even sometimes prevent some things that they may be at risk for.
Thank you, Dr. Riggs. The reason I went in listening to you and picked that up was about years ago, maybe 2008. I don't know exactly the year, but I realized my dad had diagnosed with cancer, right? So I was stressed because I'm so close with my dad. And it happens within that timeline that I had to see my doctor, right? When I went to my doctor, I never had a history of high blood pressure or anything like that. The doctor actually, this provider I've been seeing for years, instead of spending time to talk to me, ask me a question, have I changed anything? Have I changed anything in my life? Has anything changed? Physically, emotionally, psychologically, none of that happened. the best tool of this provider was to say, well, let's put you in 2.5, I think 2.5 milligram of Novask. I think that's what the medication was. And I'm looking at this man like, are you serious? Like, seriously? Like, there's no question, no assessment, nothing. So I left, never took any medication. 6 months later, I came back for a follow-up. And it's like, oh, 2.5 milligram is working. Keep, taking it. I said, doc, never took the medication. And it's like, what happened? I said, well, unfortunately, you didn't ask me the question you should ask me. And there's a couple of things that could have happened. Me with low health literacy, take medication that I don't need. Then, furthermore, I'm going and dealing with side effects that I don't have to deal with, right? So I think providers need to change their practice. It is 5 minutes phenomenon. Patient will have an appointment coming 30 minutes early. They wait for another maybe 20 minutes. They come in to see a provider. It's only 5 minutes. And then nothing, no interaction, nothing happens. You just, okay, well, take medication. So I think that part of medical practice is not best practice at all. That needs to change. And I think providers, medical doctors should start speaking up on this to their institution to change their practices. But I'm just saying that to come back with the term you coined here, methodology that meets their psychology, is very, very important. Thank you so much for that. Now, I have to move forward in this. Can you go forward and talk about practical applications of your 9 themes in public health and also clinical setting and community setting?
Thank you so much. Happy to expound. So this would be the answer for me providing the psychology to meet, or providing the methodology to meet the psychology of my target population. And this is what came up with the practical applications. So enhanced team-based care models where African-American women's needs are addressed and solutions are calculated efforts among healthcare providers across healthcare settings. So what do I mean by that? We hear this term enhanced team-based care model. So what do I mean specifically from my research study? For example, if we're going to incorporate medication for our patients, we need to also incorporate pharmacists for medication adherence, community health workers to help guide with patient navigation. We can definitely utilize nutritionists and dietitians for healthy eating and physical therapists for physical activities. And this can be taking place, again, just with that 5-minute conversation and seeing where we can meet these people where they are. Care delivery for African-American women should be informed by health equity and tailored care. Having a cultural humility setting for African-American women, listening to how we feel about our health and using that to provide adequate care. Social determinants played a role in gestational diabetes and type 2 diabetes health literacy. Collaborative conversations with policy change successfully implemented concerning these and other areas of social determinants of health should be echoed by healthcare professionals to public health authorities and also to the local government.
Thank you, Dr. Ree. I hope, in Indiana, maybe some of the recommendations you made can be implemented somehow using a targeted approach, and both in medical field and also in public health. Those are important. But the most important thing too is for people to hear your story, to hear where you are right now with your story. And also, I believe there are so many millions of Teirras out there that has gone through what you've gone through. And the funny part too, the last podcast we did about HIV, education played a role in that. Now, education is totally different from health literacy, but they can inform each other, right? So in your study, one of the themes you also found was health literacy and knowledge. So that being said, I think people have to also invest in themselves in terms of conducting certain studies, not just saying, oh, doctor told me that this, but you have to be a self-advocate for yourself by, if you get diagnosed with something, look at other alternatives, look at things that are out there that can help you there, and then have that conversation with your medical provider. Now, I'm not making any medical recommendation, but this is more like a common sense thing that we individually are responsible for our lives. We paid insurance. In fact, $327 billion I mentioned earlier, that is the cost of diabetes, is coming from each single one of us. Taxpayers' money. That's the money we're talking about. It's not government money. Government doesn't make money. We make money. We give it to the government. So we need to also pay attention to that. So that being said, let me open it up to everyone. Unless Dr. Teirra, is there anything else you want to add before I open it up to everyone?
Well, I just would like to say thank you, everyone, for your time, especially hearing my very sensitive story, which this is the first time I've shared publicly in 10 years. This happened a decade ago, in the loss of my daughter, which was due to the lack of quality medical care and my cries not being heard. And so from there, I believe that ignited a flame in me, because during my research study, I discovered I was not alone. Someone else had lost their child due to gestational diabetes and the misdiagnosis of that. So I truly know this research, and I know it because I lived it. And it's something that is very dear to my heart. And I'm happy and open to hear for questions, comments, and even concerns. Thank you so much.
Thank you so much, Dr. Teirra. Riggs, I'll open it up now for open discussion. Bring it on, ask questions, make comments. If you want to also share stories, that's fine. We listen. This is for the public to know more about diabetes. And if you feel like you don't want to talk and you want to put your question in the comment, you're welcome. Okay, Danielle, go ahead.
Yeah. So thanks very much for this presentation at first, and sorry for what happened to you. But talking about children, my question concerns the children from women who had this gestational diabetes. Does that predispose them in life to develop diabetes earlier?
Thank you so much for your question. There is research out there that suggests, specifically for mothers who have had gestational diabetes, that their daughters have a higher risk. I believe it's 4 to 6 times higher risk to be at risk for type 2 diabetes sooner and later in their life. And as a mother who birthed a son who I believe would be at risk as well, I have him tested yearly just to ensure his blood sugar levels are where they're supposed to be, just as a preventative measure, knowing that he was unfortunately predisposed during my diabetes journey.
So you would suggest that all, at least the females, and even the boys, I think,
absolutely,
get tested regularly, even at early ages?
Absolutely. I had him tested when he turned 3, from the age of 3. He's now 8.
Yeah, and he's free of diabetes.
He is free of diabetes.
Good. Thank you.
Thank you.
And to say and to add to what Dr. Riggs said, and great question, Danielle, is that at least she's informed. And think about scan through America right now, or the world. What are the mothers or the fathers that are not informed that, okay, well, they don't. So chronic disease, I always say this, it's not like infectious disease, okay? Infectious disease with viruses or bacteria have usually short incubation time. It could be 7 days, it could be 3 days, it could be a month, and you start seeing all the effects. Chronic disease people has a longer incubation time. Some people might think they're okay, and they're not seeing the symptom or phenotype of that particular issue. They think it's okay. Continue screening. And also, once you already know, like Dr. Reese already mentioned, that you already predisposed, invest in lifestyle modification, lifestyle change, nutrition, specifically for diabetes and for any other condition, including cancer. There are so many things we eat, we put in our body that's carcinogen, that's a risk factor for diabetes. There are so many cardiovascular diseases. I can go on and on, but that's the point. You know, like we need to be informed. We need to have the education, self-taught, or learn from other people or even from providers. But ask the right question when you meet your provider. And then another suggestion from me is if you feel like your provider is not hearing you or is not paying attention to your concern, leave. Find another provider. You don't have to stay with that provider, you know? So, I mean, like, that's a job. He's doing a job, but I guess he's not doing it very well. Look for somebody else that can listen to your needs.
That's what I did. I just had to move across the country, but
There you go.
it's possible.
Just to complete, is gestational diabetes increasing just among the general population?
I'm sorry, could you repeat your question?
Yeah, just in the general population, not only African Americans, but general population, is it increasing with time?
Yes, unfortunately. And I know specifically for the state of Indiana, that gap is widening.
Actually, great question. I think I have this surveillance here, but it's not really about gestational diabetes. But let me share this screen. So this is directly from CDC, right? So you can see that the trend of this is diagnosis of diabetes, and you can see the trend of it. Right now in 2020, it dipped a little bit, but overall, you can see the trend is increasing. We have, usually this data come in 2 years late. So we're in 2021 right now, right? So the 2022 data might show up later this year or maybe next year. But you can see it's increasing. So I just want to share that. I have it handy, but I know you didn't ask for diabetes, you asked for gestational diabetes.
Okay, thanks.
Oh, you're welcome.
I apologize for the noise. That's my 4-pound, 10-ounce baby boy. Who's now 70 pounds.
I'm not seeing any questions in the comment.
I have a question, Professor.
Okay,
this is
Dr. George. I guess everybody is shy to be on camera. What's that?
Because we are getting old.
Okay.
All right, my question, it's not a question, but probably something to throw into the discussion is gene, since we have this prevalence of type 2 diabetes among African-American women, probably among African women per se, is gene responsible for this type of problem genetically, gene mutation? Is there any relationship to gene mutation? Because genetic mutation, it can cause diabetes that affects protein that plays a role in the ability of the body to produce insulin, or in the ability of insulin to lower blood sugar, glucose.
Mm-hmm.
I don't think the study was extended to this aspect, but there's a likelihood probably it might have something to do with gene, because when we are talking about African American, I don't know about the data people in Caribbean, Africans in West Africa or Central Africa will also probably have the same level of prevalence of this type of illness.
Mhm.
That might be another study, right, Dr. Reich?
Yes, and so just to make sure I'm understanding what you're asking correctly, if there's a genetic predisposition with diabetes because of our being African American.
Exactly, a common descent. And I
For
think
my
it's like, go ahead.
So I will say, based on the data and the research that I had presented, not specifically for this, but a very good question, for type 2 diabetes, specifically for African-American women, yes, based on the inclusion criteria on my study, most of the women had a familiar history with gestational diabetes, or this was a co-occurring issue. So for me specifically, I did not even know I was predisposed as being a type 2 diabetic, as both of my parents became type 2 diabetics after the age of 50. And I am in my 30s. So there was a lot of misinformation, a lot of things that I had to ask on my own, my independent resource, and being my own advocate. But from my experience and based off the research, I can definitively say that I do believe there is a predisposition to chronic disease, but that's why lifestyle change, nutrition, and diet plays a huge role in even preventing or delaying the onset.
Very good, thank you.
Thank you.
And just also
Well, to continue, to continue on that, just are there any statistical studies between people living in Africa and African Americans?
Oh, like a cross-sectional study. That's a good, I don't know off the top of my head.
You see, if you take 100 people in Africa, you test them, and then this is supposedly, then you send them to the United States. They change lifestyle. Do they develop diabetes, gestational diabetes more frequently than if they stayed in Africa?
I think in terms, Daniel, in terms of epidemiology, what I do know is that, in a review I wrote, I discussed this a while back, that if you look at African continent overall, African continent has higher level of infectious disease and communicable disease, and overall has the lowest among any country on chronic disease. That includes diabetes.
Yeah.
Then it's the opposite in developed countries. Mostly developed country has the lowest prevalence of infectious disease, but the very high prevalence in chronic condition. But now my prediction is in the next 20 years, Africa will have the same or higher number of chronic disease. Why? Because you have to always look at, when we talk about predisposition in the body molecularly, the body goes through a lot of mutation and your gene can deal with those. But mutation doesn't just happen in vacuum. It happens due to the environmental exposures. There are certain things now we do, in this modern day that actually cause a lot of mutation. I did my research on cell phone radiation. Cell phone radiation causes mutation, right? You don't know what's happening. The food we eat now, the way it's made and put together, processed food, also you consume on daily basis, overall can cause mutation on a gene level or chromosome level, right? So I think the take-home message here without going into pure molecular analysis, molecular biology, is that we know type 2 diabetes specifically, not type 1 diabetes, but type 2 diabetes specifically can be delayed and prevented because by just simple lifestyle modification. That's, majority, if we remove those that have familiar history, which is not that many compared to those that do not have familiar history, I think we'll come to agreement that this is a modifiable condition. And even for those that have familiar history, For them, knowing about it, knowing what they can change in their lifestyle can help them actually delay the onset of type 2 diabetes and mitigate the chronic condition. That's my take on this.
Okay, thanks. You would say then that is not really purely genetics. At least it's not birth genetics, it's not hereditary, it's not something that happened, I don't know, 30,000 years ago. A certain population developed genes that predispose you to diabetes.
Can I inject something here, sir?
Go ahead.
I think there's a likelihood that it might be genetic related. Something like sickle cell anemic condition. We have, I think, 12% of African Americans that have sickle cell. And sometimes you go to Africa, especially West Africa and Brazil and the Caribbean, you find this almost the same percentage in terms of sickle cell anemic condition, which is in terms of gene mutation.
Yeah.
So there's a likelihood that there's a relationship between gene among Africans with this type of, especially like gestational diabetes, which she mentioned, which likely it might not have anything to do with your diet, but like if you have a baby that is overweight during birth, there's tendency that that baby might develop diabetic conditions. And in this case, it has something to do with gene.
Yeah, and I think last time I also talked about something called Thrifty Phenotype. And the phenomenon of Thrifty Phenotype simply means this. For example, if you take a woman that is pregnant and that woman is living in underserved community that's impoverished, meaning this woman over 9 months period or even before pregnancy, it's not living well in terms of healthy nutrition, right? When she's pregnant, what will happen is that the baby or the fetus develop a mechanism to conserve energy. So whatever the woman takes in, the baby develops internally energy conservation because that baby has to survive, right? To conserve energy. This will happen all 9 months. And then the woman will deliver the baby and the baby goes back to the same environment. I mean, delivering baby doesn't change the socioeconomic status of that woman. You know, if she's poor, she's poor. The baby will continue, you know, malnutritional condition will still be in that environment. Now, study has shown that if you end up maybe a few years later, maybe 5 years later, 6 years later, take that baby away from that environment, push that baby in an environment where there's abundant food or whatever, right? That baby is more likely to be obese. Guess what? That baby becomes obese now, that baby more likely to be diabetic. See what I mean? So over time, the biological body has been conditioned to conserve energy, and the environment plays a role. I think we have gone away from that gene, one gene type of mentality in terms of causation of disease. Environment plays a role as well, and that's why it's interesting when Dr. Riggs discussed about social determinants of health. It's very, very important to account for that as well. Yes, gene plays a role, but also environment plays a role. Both things work hand in hand. If we understand them better, we will always be in better position to take care of all these chronic conditions. But that's a great question from George, and that's a great follow-up question from Daniel. Thank you so much for the questions.
Yes, Dr. Omalo.
Hi, William.
Yes, Coach William Power. Dr. Riggs, I would really love for you to expand from your great research, the answers that you've put together and the things that you've learned and helped yourself personally, and focus on spreading that news of how to, reverse or prevent diabetes, because it's real. And I know that you're up against a lot of difficult situations, as we are, all of us, to even do so, because as Dr. O'Malley has mentioned himself personally, when he was put on medication, never took it, and he changed himself. It's mind over matter. It's environment. It's how you feel. And you touched on this, Dr. Riggs, on the women, how they feel. And almost every situation, if there was a simple line, were they feeling fear? Is it fear-based or is it love-based? Everything that you've discovered was fear-based. So the answer must be love. If they had self-love, if they felt good about themselves, if they had, if they would eat differently, they would choose better foods. They would, when I feel bad, I like potato chips. When I feel great, I'm going, what am I doing? For me personally, as an example. So, and also, if I'd like to add, you're up against a tremendous thing that Dr. O'Malley talked about, which is the money game. You're discovering the answers. You've done incredible work. You've walked the talk, and we need to get you on stage and gather people together. There's more of us than there is of them that are pushing this agenda with the money, because it's big business.
It is.
And a friend of mine put this together and told me, the doctor is the drug dealer. They don't even care about talking about how you feel anymore. They don't touch you. They don't want to touch you. They get sued. It's America. The big pharma is the drug supplier. Scientists are the drug certifier. The media makes us believe they're the drug marketer. The government is the mafia. And the philanthropists are child traffickers. I mean, that's what we're up against. You have the right answers there, because you've got the answer why they're sick, why they have diabetes. So you just do the opposite, and that is find ways. If it's the food that's going to make you feel good, it's lifestyle, it's exercise, it's the way you think differently. And just to add into this gene thing, a friend of mine, Dr. Bruce Lipton, I don't know if you know of him, cell biologist, he's been preaching. They thought he was Looney Tune like 25, 30 years ago, when he was saying that the gene, and he's been preaching this for over 25 years, but it goes against all the models, okay? Epigenetic medicine, it goes against all the models that are in place today, meaning that the gene, it's not gene driven. You go to a doctor and they give you a list. Does your parents have diabetes? Did they have cancer? Well, you'll probably have it too. It's not that they had it. It's what has happened here. And you guys have touched on it, Dr. Mella, and yourself with your research. You've touched upon it. And what I'm trying to point out is what's hereditary isn't the gene, according to Dr. Bruce Lipton's work. It's the behavior behind the gene. The gene cannot do anything by itself. It's the behavior behind the gene that drives it. So what that means is what's hereditary is that you take on the environment of your parents, the way they act. So that's what produces the sickness. If you came from parents that were very poor and fear-based, and they died of cancer and diabetes, but the one child was adopted to a family that was love-based, and they were treated with love, and there was no hatred, and there was no nothing, that it was all love. Their genes wouldn't go the way of their parents, is what Dr. Lippin has proven here with gene therapy. The gene cannot, it's not the gene, it's driven by the behavior behind the gene. And he's proven this. And read his book, Beyond Biology of Belief. Read his book. And he's been talking about this for almost 30 years, and he's finally getting some recognition. So you've touched upon the answer, and I really would love you to find a way to not take your research and take your personal story to the streets and get people to wake up, because it's important to work with Western medicine, not to be drowned in it and being told what to do, as you told about the white coat theory. It's important to be in charge of your body. It's your body, not theirs. You know how you feel. They don't. So I'm encouraging you on every level. You got so much. You're a good speaker. Is to go to the next step, and there's more of us than them, the money people, and it's always, and the money people, they're brainwashing a lot of the doctors. So they come through med. I teach at medical schools. I'm brought in, all these graduating students becoming medical doctors, and I'm brought in and I'm teaching them what they don't teach you in Harvard Medical School. Okay. I'm brought in to teach them that, hey, you're forgetting, you weren't taught what your grandparent doctor knew about medicine and how to take care of the human body. It's based on taking care of its behavior, spending time with a patient, not 5 minutes, write a prescription. This is how they're trained now. And I'm brought in to wake them up on this fact that the perfect doctor of the future is one that does both.
Thank you so much. Thank you so much, Coach William. I mean, I always say this, science is science, but at some point, and a lot of people noted that we have believed that protein was the foundation of everything that happened in your body. Until Watson and Crick came out, we drop all that protein phenomena. It goes through the door, out. It's gone. The model changed now to gene expression and all that. And then epigenetic comes out. We're realizing gene doesn't function by itself just like that. The environment happened. The protein can fold differently due to the environment and confers a different phenotype, right? So these are known. So, William, thank you so much for the additional information you provided. There's interaction between gene and the environment, and we need to be conscious of that. And before I go to Abdul Rodney, let me read a question from Mark. I think you covered this. Thank you, Dr. Rees, for a job well done. Please, my question is regarding this study population. What sampling method was used? From your narrative, data collection was through FGD with 7. I don't know what's FGD, but with 7 women with lived experiences with gestational diabetes, and I assume it was 1 FGD for validity
discussions.
I'm sorry?
Focus group discussion.
Oh, focus group discussion. Okay, thank you so much. Okay, why was this limited to 7 women? Secondly, how were the themes for analysis derived? Did your background research, your experience and education, or the data you review inform the themes?
Okay, thank you so much. I'm happy to.
You want me to repeat it, or did you get it?
I understood. I was reading. I'm happy to answer your question. Thank you for asking. So I used purposeful sampling for my research because it was information rich and it went along with my phenomenon of interest. And I also used 7 women. Again, this was a purely qualitative research study. In qualitative research, there's not a huge sampling number. And also, the information was so rich during my data collection that I started to get some of the same responses over and over. And so that's when I had stopped the interviews at 7 women. So my data analysis, my themes, I derived them because I use in vivo 12 as my data analysis. And from there, it took about a week, but I took every single description and dialogue from my participants and constructed them into common words and themes that were deriving during their interviews. Along with that, and I tried to remain neutral as, with my personal experience and not to bring in some of my bias during my analysis. So I'm hoping that answered your question. And so the one focus group interview was because I had numerous women during that interview, but the one-on-one sessions were due to having focus group settings, but just one woman showing up. And so not to dismiss her information or her experience, I constructed it from one focus group interview which had 4 women, and then the following were one-on-one interviews.
Thank you, Dr. Riggs. Usually when we conduct qualitative study, if you go in literatures, minimum five participants, 3, 5, sometimes people go up to 12, but usually qualitative study is a very small sample size that usually used in qualitative study. Quantitative study is a totally different thing, but she's within the right sample size. Thank you so much. And then somebody had their hands up. Rodney, go ahead. Rodney, you're muted.
Yes. Can you hear me now?
Yes.
Can you hear me?
Yeah, we
Hello?
can hear you.
Oh, okay. Okay. I want to say thank you, Dr. Amilu, and also Dr. Riggs. I apologize for being late. I was very late. It really could not be helped. But I really appreciate all the portions of your presentation that you gave. I want to make just first a brief comment, but then I do have a follow-up question. I am currently, I'm a cancer patient, and I had to change my primary physician several times because of the very issues that have been brought up during your presentation. Lack of quality care, because my physicians were not asking the pertinent questions that you brought into focus during your presentation. And I agree. I kind of see it as you're presenting that medical physicians should perhaps take on more of an integrative medicine way of dealing with their patients. And I'm in full agreement. Certain questions that address, as you stated, where their head is. So with that, here's my question. In regards to treatment of African-American women with gestational diabetes, when you mentioned, and maybe it was an oversight on my part, but when you mentioned about a social component, now I'm talking about in terms of the treatment for African-American women, would the social component include African-American women meeting in groups, support groups? Because it's my understanding, based on my personal experience and several.
Rodney, you're breaking up. So I think Rodney, okay. Nobody, I can't hear Rodney. I don't know if any other person hearing. Okay, he got disconnected. But if you want to talk about some of the stuff you brought out, you can talk about it.
No,
I think I saw another comment in the comment section, but go ahead.
I think he was asking about if there was, I hate to answer it if he's not on, if there were benefits to African-American, like having treatment in groups, like group treatment. I love that idea too, because that's why I mainly focused on having focus group interviews, because during that time, I felt that the women kind of not necessarily piggybacked off their answers, but they felt more inclined to share as people were more transparent in the groups and speaking about their experiences. It created a very, and that was my longest interview, was my focus group interview, where the women were able to really see and understand that they weren't alone, and that their experiences were unfortunately similar in that respect. So I did find that to be very beneficial as I collected research in my study.
Great. I have a comment by Kemia, and she said, "Thank you, Dr. Reed, for sharing your story. As a Black woman in some regions, particularly in the United States, have also been observed to have even higher rates of maternal mortality and complications during childbirth compared to other racial and ethnic groups. This issue is often referred to as racial disparity in maternal health outcomes. I would like to be a mother one day, and hearing your story gives me a greater understanding as to how I can improve my health literacy. Dr. Rees, considering your enhancement-based model, I agree with William. You did great job." And in caps, "I believe you should consider adding yourself to the enhancement model." Okay, through community workshop and seminars, I agree. I believe African-American women, healthcare providers, etc., need to hear this research, your story, and better learn to be more preventative as well as self-advocates. Thank you. And Kemia, thank you so much. Well said and well summarized. I totally agree, you know, and I told her one day, I told Dr. Rees, you need to go to TED Talk, you know, but this is an amazing story and amazing discussion. I agree with William, I agree with George, I agree with everybody, Danielle, everybody that made comments into this discussion. And we need to continue working together to find a common ground in terms of modifiable health conditions to solve this problem. This problem is solvable. $327 billion, I can't get it off my head. That's a lot of money. That's a lot of money for a disease that we can handle. It's a lot of money. And the funny part too is that when you look at that money, $327 billion with a B, most of it doesn't go to care. Most of the money we talk about, it goes into what they call administrative, whatever they call it. But it just, it's crazy. But that's a different topic. But thank you, everyone. I don't know if any person else has, there's a lot of thanks in here from Nemeka and so many people to Dr. Riggs. I don't know if any other person has any comment before I close this out. Okay. Thank you, everyone. Thank you for attending this podcast. Oh, by the way, please subscribe to our channel. You know, please support us, Popaholic. You can go to YouTube, Google Popaholic show and podcast and subscribe. This video will be on Popaholic podcast, I would say tomorrow. And then you can also, if you really love what Dr. Teirra shared in here, then take it upon yourself. Go to our YouTube channel, take that video that I'm gonna post, and then share with your family members. This is the only way not the only way, but one way for you to make contribution in this discussion, sharing the message. You don't have to be a provider. You don't have to be a medical practitioner. You don't have to be in public health. You don't have to be epidemiology, but getting an information that you think can help your family members and sharing that information with them, you are also already helping. Like William said, we need to be together on this and work together to promote healthy lifestyle. And then, there are certain diseases that you might take medication or, invest so much in medication, but there's, some diseases that can be prevented. And I use myself as an example where I could have been in medication, but I know better. And I say, I'm stressed out. And it's obvious when you stress out, your blood pressure goes up. That doesn't mean I have to be taking this medication. So, I'm saying this to say, please be vigilant and pay more attention. Public is all about healthy discussion, healthy people, and healthy environment. That's what we want. That's our goal. So thank you everyone, and have a wonderful weekend. Thank you, Dr. Riggs. Thank you so much.
Thank you.
Yeah.
Appreciate it.
Thank you, Mr. Professor.
Thank you.
Thank you, Dr. Reed.
Thank you. Thank you, Dr. Riggs. Thank you. Good to see you.
I typed in further studies in this area. Maybe we might have to look at the relationship of gestational weight during pregnancy to the incidence of type 2 diabetes.
Yeah.
Oh, that's true. And before I close, the next show coming is University of California, Davis, Professor Facchiotti, Dr. Facchiotti, and Andrew Yang will be presenting on tissue engineering. So I welcome everybody to attend that. The next show will also be Dr. Emenambo presenting on it's gestational weight gain and its impacts in infant mortality among women in Mississippi. So this is also, again, comes to this pregnancy thing. So it's very important. So I wish everybody can attend. And when I share the flyer, share with your family members to attend this podcast. This is very, very important. If you cannot not attend, that's fine, but share the videos. Thank you so much.
Thank you all.
Thank you, everyone.
Thank you, and congratulations, Dr. Ray.
Nice weekend. Bye-bye.
Thank you.